Okay, so it looks like we can probably get started now, and then the last few people will trickle in. So welcome everybody. Thank you so much for coming, especially of those of you who have been at the symposium for the last few days. I really appreciate it. Just to briefly introduce myself, my name is Georgia Hacker. I am a first-year master's student in the Department of Family Medicine. I'm working under the supervision of Dr. Isabelle Vidal and Dr. Claire Godard-Sebillot, researching the impact of COVID-19 on persons living with dementia. I'm also the incoming Vice President of Academics for the FMGSS next year. So I'd like to now introduce our speaker for today, Dr. Vladimir Khanassov. Dr. Khanassov completed a master's thesis, the Family Medicine Residency Program, and a fellowship in care of the elderly in the Department of Family Medicine at McGill. Dr. Khanassov is currently practicing in the Division of Geriatric Medicine of the Jewish General Hospital and the IUGM. He is also assistant professor at the Department of Family Medicine at McGill University. He is currently developing a research program focusing on the needs of patients with dementia and their caregivers in primary care. This seminar is titled Primary Care for Elderly People, A Career Trajectory of the Academic Family Physician. And just before we get started, I would like to remind everyone that the presentation will last about 25 to 30 minutes, followed by 25 minutes of discussion period. This seminar, as you could see earlier, will be recorded. So if you'd prefer not to be in the recording, please feel free to keep your camera off for the presentation. And finally, any questions you have during or after the presentation can be either posted in the chat or feel free to raise your hand using the participant raise hand function during the discussion. So thank you so much. I'll now pass it over to Dr. Khanassov.
Thank you, Georgia. Thank you for invitations, Dr. Vidal, who invited me to present a little bit about my research, and she suggested to present my journey from the beginning of my first steps to the stage where I am now. So if you look at the title, I'm going to talk a little bit about the primary care for elderly people. And from the beginning, I would like to start with who I am. Some of you know me, but most likely majority of you don't know me. So I'm a family physician at the Herzl Family Medicine practice. I completed my residency at St. Mary's Hospital with additional training in care of the elderly. My practice is a full regular practice at Herzl. Predominantly, I see complex patients with the multiple comorbidities. Also, I work as a consultant for geriatric complex patients in our Herzl clinic. We called it Herzl Elder Care Clinic. So I see patients referred by family physicians and the residents for the assessment of some complex condition that sometimes requires some co-management. Also, I work as a consultant at the geriatrics of the Jewish General Hospital. We call it GAU, Geriatric Assessment Unit, for the patients referred outside of the Herzl clinic. The main categories of the patients I see as a consultant, apart from my family practice, it's a memory decline, behavioral symptoms management. So I do co-management with the family physicians on the control of the behavioral symptoms related to dementia. Since recently, I've started doing capacity assessment for majority of the patients that I see for capacity assessment. It's the patients of our residents at the Herzl Family Medicine practice, and also do a lot of caregivers education and support. And if you look, I put the geriatric doula specialist. So if majority of you most likely know who doula is, a doula is kind of non-medical professional who guides the pregnant woman from the beginning of the pregnancy until delivery. So I consider myself since last few years like a geriatric doula, because I accompany the families of the patient with a cognitive decline from the beginning of the diagnosis until the placement or until the end of the life of my patient. So it's a co-management of the patient with the families. Also, I work at the Institut de Gériatrie de Montréal, which is a Centre d'Excellence de Gériatrie in Montreal. So I have my own unit, long-term care unit, and also I'm on a weekly geriatric call for the geriatric rehab and post-acute units at the same institute. And it's about my clinical career. And we'll talk about research career because that's the main what the topic is about. My academic career started before the residency in the family medicine. So it was between 2012 and 2014. Under the supervision of Dr. Vidal, I completed the project for which I received the FRKS MSc bursary. So my project was on the case management of patients with memory decline in primary care. So what we look for the existing evidence on the impact of dementia case management on patient outcomes and system outcomes. The case management is a model in the primary care when the family physicians assisted by the nurses in the diagnosis, management of the patients, follow-up, and liaison with other healthcare professionals. This model is a key element of the provincial Alzheimer plan, which has been implemented across all GMFs in the province since 2014 about, and under the multiple studies for the evaluation of the efficacy of this model. So the results of this first study in my career showed that the case management for dementia in primary care could help with the control of the behavioral symptoms of dementia. We're talking about non-pharmacological interventions, decreased burden and depression of caregivers. The results of this study, they were published in the top journal of the specialty, the Annals of Family Medicine and Clinical Intervention in Aging. When I finished my bursary, I started my residency at St. Mary's Hospital. Unfortunately, I had to decline, or fortunately, I had to decline the FRQ's bursary for the PhD. During my 2 years of the residency, I completed another project, which was the logical continuation of the first project. I looked at the impact of the same model on the needs of the patients and their caregivers. So we looked more at the patient-oriented approach. The design of the studies received the first Patient Choice Award at the NAPCAR conference. What we found out that case management in primary care is able to provide a better quality of dementia care and continuity of care, education on the disease, confidence in caregiving, but we were not able to timely diagnose the dementia in primary care. So both these studies, the first one and this one, it was systematic mixed studies reviews using different approaches. The first one, it was with configurational comparative method, when we look at the condition that should be respected in primary care in order to achieve the desired outcomes for the patients and the system. And the second study, it was more with a meta-analysis. We tried to see the real impact of this intervention on the needs of the patients. This study also, it was published at the Annals of Family Medicine. When I finished my residency, I received my FRQS Junior, Junior Clinician Researcher Junior 1, and I was hired as assistant professor at the Department of Family Medicine. During that time, I started in 2017, the third project, I would say, which is the same, the third step of the same topic on the case management for patients with Alzheimer, with dementia, and their caregivers. But this time it has been an experimental study. It's mixed method experimental study using sequential explanatory design. What we tried to do, we tried to design the study with two different steps. The first step, it's a quantitative study when we tried to measure the needs of the patients and with dementia and caregivers in primary care using the two validated tools, KNA, KND, in 3 family medicine practices, Herzl, CLC-Codanesh, and the Fabouch, which is a GMF of the Institut de Montréal. So we'll look at the rate of met and unmet needs in the sites in which the Alzheimer Plan of Quebec has been implemented. And also the second step, we also had a qualitative study when we conducted a qualitative interviews with the patients and caregivers with a high number of met needs and with a high number of unmet needs to look what's the possible causes of met and unmet needs that we could, based on that, we were thinking to modify some interventions that could be changed or added to the existing Quebec Alzheimer Plan. So this study, it was funded by the CIHR, FRQS, and RESO 1. And during this study, one of the MSc students, one of your colleagues, Martin Young, who was supervised with Dr. Waddell and myself during the 2 years, he completed this project and he will be a psychiatric resident from July 1st. Unfortunately, he decided to leave the family medicine, but he will stay with us. So the results of this study, they show that Alzheimer Plan of Quebec in the way that it's implemented is able to address majority of the needs of the patients and caregivers. But what we found out, we have the trouble focusing on the education of the patients and caregivers on the disease itself and on the prognosis. In general, patients and caregivers, they were satisfied with the care that they received in the family medicine units, but they were open to the alternative, such as a nurse practitioner, to be co-followed with their family physicians. Especially it was valid for the practices of the family medicine residents, because every 2 years they change the patient, they change their family doctor due to the 2-year cycle. And it was with the idea of the one of the dyes patient and caregiver to have a nurse who will co-follow them across all their time that they stay in the family practice, to make sure that the continuity of care is preserved, because they find that it's difficult to change the family doctor every 2 years. But this aspect, it's pertinent only to the teaching units in family medicine practice. The results of the study, we are almost done. Unfortunately, we couldn't complete the study due to COVID-19 in another unit, so we have to finish it earlier. So the study is in press in the Canadian Geriatrics Journal, and we are reviewing the second round of the review for the BMC family medicine practice. And where are we now? That's a two different projects that I would like to discuss with you, what we are working on, the development of two projects, because COVID-19, it changed the paradigm, let's say, the way we treat our patients for all of us in family practice. But if it's more or less working well for the patient without cognitive impairment, for my elderly patients and patients with dementia, it's not so easy to provide the care through telemedicine. So the research project that I've been developing with Dr. Widell, we're working on the project Telemedicine for Older Adults with Dementia in the Community. It's one of the projects, and another project I'll present to you a little bit later. So the first project, which is a halfway now, it's a project which was funded by the College of Family Physicians, and we also are waiting for the funding from Janus and FRKS if we are successful. It's another mixed method study. We are using here sequential exploratory design, which contains of two different steps. The first step, which is a part of Marva Ilali's MSc program, one of the students at the Department of Family Medicine of McGill, will look at the effects of telemedicine on older adults and adults with dementia in routine primary care. Why I'm emphasizing routine primary care? Because prior to COVID-19, we had a lot of different interventions of telemedicine for particular outcomes, let's say control of blood pressure, control of level of glycemia, but we don't have real intervention looking at the in general for routine primary care. So we're trying to find out what the impact or effect of telemedicine on the patients, elderly patients in primary care. And based on this first step, we'll go further to the second study, which is a qualitative study. When we talk with the patient, with older adults and adults with dementia, we'll explore their experiences with the telemedicine in 4 primary care practices: Herzl, CLC Kodanesh, CLC Mitroy Park Extension. So this second part is under the ethics review. Hopefully by the end of this month, we'll get the approval and we'll start the project. Using the results of the first step, which is a systematic review, we'll update our approach to the second study, because it will be qualitative study. In the qualitative study, one of the R3 in care of the elderly participated is Dr. Kadur, who just finished her R3. She helped us to develop the qualitative questionnaire that will be updated later based on the first study. And the second study if we look at the preliminary results of the first systematic review, it's still very preliminary, because Marva, she's in the way to analyze the data. But what we know about the telemedicine for older adults, we group them to two different categories, two different themes. The first theme is attitudes toward the technology used by elderly people, and the second category, attitude toward telemedicine. If we look at the left side of the slide, we see that elderly patients, they have a positive attitude to technology. They have some concerns about the cost of the equipment, but we need to look at that, because they are talking about the specific interventions prior to COVID-19 when they had to install something at home. So it's not really valid for the current period of time. They are concerned about the ease with equipment use. they have a limited trust in e-service, and very often they had the technical problems with video consultation. In terms of the attitude toward telemedicine, they find that telemedicine it's a good source to monitor their health status. They have positive attitude to video consultation, especially for the patient with a limited mobility, with the mental health problems, working elderly patients. They prefer video consultation in comparison to phone consultation. They are okay with teleconsultation if it doesn't require the physical exam. However, for complex sensitive problems, they would prefer to have a face-to-face consultation. And if we look at the preferences based on the preliminary review of the literature, traditional face-to-face care practice, it's on the first place, then video consultation, phone consultation, and the fourth place, they accept combination of telemedicine and face-to-face for certain situations. But all this, what you see on the screen, it's based on the studies done before COVID-19, when the telemedicine, it was more for remote geographic areas, for the specific conditions sometimes, but not globally used telemedicine like we are using at the current moment. The second research project that we are developing with Dr. Vidal, we're trying to develop the project on the impact of telemedicine on health service use in adults with dementia, their caregivers in rural and urban regions of Canada. It's a more a multi-provincial project. It's also mixed method study, but this time we use a convergent design. So it means convergent design, so it's two studies in parallel. One of them is quantitative study, quasi-experimental study, when we looked at the use of the health services in 4 provinces of Canada: Quebec, Ontario, Alberta, and Saskatchewan. We will look at the impact of telemedicine on the acute service use, avoidable or sensitive to family medicine health conditions for patients with dementia. And in parallel, we will conduct a qualitative descriptive study based on 2 surveys. One of them is a survey on the experiences of the patients and caregivers using the results of the Alzheimer's Society of Canada survey, and the second on the experiences of family medicine with telemedicine with the same patient, distributed by the College of Family Physicians. So we're waiting for the funding for this project. It was submitted to FAMF, Foundation for Advancing Family Medicine, FRQS, and Drummond Foundation. That's a nutshell on my presentation today. I'm open to any questions that you might have.
Thank you so much. Oh, sorry, my video is not on. Thank you so much, Dr. Khanassov, for that presentation. Like I said earlier, the chat function will now be open in case anyone wants to type any questions in the chat. And I'll also be monitoring the participant hand raising function. So if anyone has a question, please go ahead.
Well, while people think about the question, I just want to thank you. And I think, Vladimir, you showed well your career track and what's the beginning as a clinician scientist. So I think that was a great demonstration and you're very successful. So congratulations for your career and the presentation.
Thank you, Alexandra. Thank you. That was an objective because the title was trajectory. So we tried to, Dr. Vidal asked me to present trajectory. So I presented trajectory from the beginning to where I am now.
I'm sure it will inspire many other family physicians, residents, medical students who would like to do both, to be involved both in research and as well in clinical practice. So thank you so much, Vladimir.
If there are no other questions, I would like to ask a question.
Absolutely.
Yeah, so I'm in the Clinician Scholar program and will be doing my master's too. So as a clinician and who won't be attached to any institute afterward, I finished my residency in 2 weeks. So what will be your advice for my future, which is possible in something to do in research in the future?
Could you tell me what exactly your project you're working on?
It's not really finalized, but the broad topic is the resident knowledge on LGBTQ management.
Okay. And your concern is about what exactly? What's your concern about?
The concern will be, so I will be leaving McGill, so I don't have any institutional affiliation after that. So I will be in a clinic, and doing CHSLD and my clinical work. So for my research component, so in the future, what will be your advice?
Okay, I will answer, but I believe Alexander, our research director, she'll give you more also answer on that, because there's some also other ways to do research. For in your case, if you're planning to integrate research in your career, the first step, most likely you need to start a small project and to see how it's going. If you want to protect your time, I believe we have La Lettre 250, when you can apply and you will have your protected time. So they are asking about 20%, I believe, of your time should be protected for your research activities. And if your project is successful, you submit the FAQs, you might have up to 50% of your protective time you will have of research. That's the way how it goes. But at the same time, you need to understand, if you look at my project, it's a lot of work. It's apart from your clinical work that you will have, it will be double work for your research. So it's not so easy to balance between what you are doing in the clinic and research. It will never be 50-50%. You need to expect that you will have 100% of your research, 100% of your clinical work. It depends on which clientele, let's say, on which clinical field you are going to work. Like in my case, I work with geriatric patients. There is never a stop. I also receive phone calls. I work with a lot of healthcare professionals that I have to guide. So it's a bit more overwhelming. But if you do something simpler, just your office based, most likely for the beginning, it will be okay for you to start a small project and doing your clinical practice to test if you like it or not. Because sometimes we start doing and we realize that it's too heavy, it takes so much time. And I believe we also have opportunity in the department, if you are affiliated, to have the protected time without going through La Lettre 250. I believe our program director will explain to you, but I believe there is an option that you could have a protective time without being in Lettre 250.
Well, to be honest, it's even the Lettre 250 is now changing. So it's going to be focused on people spending at least 50% of their time in research. Having said that, I think I agree with Vladimir. If you're not too sure how much you want to invest, you can go small, and it's kind of a matter for you to protect your time in your schedule, clinical schedule with your supervisor. And then see if you like it or not. And if you do, then it's true that it's research. It will be easier to do if you want to invest that 50% of your time. Or if you want to do less, then collaborations can be easily done as a complement, even if you're not investing the full 50% of your time. We can definitely talk about that more. And for the affiliation part, depending on where you are, you can still have some links with some academic institution. So we can have these discussions whenever you want. Like Molly, feel free to connect and we can meet and we can assess. I find it really depends on each individual, the interest and the extent of time that's possible, and even the protected time. It really depends on the clinical work of the people and where they work and how feasible it is. So I welcome any meeting and we can discuss that and see how it can work for you.
Thank you very much. I know I can always count on you. Thank you.
I see on the screen the question from Dr. Cockcroft, right, about the historical controls that she asked for the second study that we are planning. So when I present this, it's still under, you were working on that. The question is, for the last research program, do we have concerns about historical controls? Yes, we do have. We are concerned about that because the first concern is not all provinces they use the code for telemedicine, because in RAMQ we added it later if the doctor they do telemedicine or not. So it was a delay in the administration of telemedicine. So we have to look at from which period of time we'll be able to extract the information for looking if telemedicine was really done from this period of time, depending on the province. We know that we have in Ontario and in Quebec, but in Saskatchewan and Alberta, we're still not sure. It seems that there is some way they are doing that, but it's not like universal like in Quebec, in Ontario. Even in Ontario, they started before COVID-19. They already had that called telemedicine, but it was not so universal like it started from COVID, from the beginning of the pandemic.
I suppose I was also concerned. The historical controls would assume that the only thing that was changing was the availability of telemedicine, but it may be that particularly recently there have been so many other things that may affect people's need or use of health services, and that may be a complication when thinking about historical controls, because you can't assume that nothing else has changed.
You're right. That's, I believe, it's inherited part of the historical controls when we use it, right? But what we'll try to look the use of the services for family sensitive condition. What we try to look at that prior to March 2020 and from 2020 until 2021. What we try to do with 12-month difference. We'll try to look. So it's possible to make some conclusions, because we are not looking back to 5 years. We look 12 months prior and 12 months during the pandemic, first year of pandemic.
Right. Thanks.
I have a question, Vladimir. So it seems that the last preference of patient from your systematic review is a mixed model between telemedicine and face-to-face. This is the least.
It's least preferable, but as I mentioned, it was done on the studies prior to COVID-19. It was intervention for specific conditions, if we look at that. That's why it's still, we need to look through the prism of COVID-19, because it was not so globally like now. So that's why what we're trying to see, based on that systematic review, we'll update our questionnaire for our patients to see if it's still applicable, their preferences before to what we are living now, COVID-19. That's how I'm seeing that, because I was surprised also to look at that. I thought that my patient would prefer to see me in person and then to have a phone call on something to discuss with them. But based on the literature, it seems that it's not something that they would prefer. You look, if we look from the perspective of the patient, it seems it's not the same like we think like a healthcare professionals. And what I see with my own patients, my geriatric patients, if I look at based on the literature prior to COVID-19, they like telemedicine because it's easier for them. They stay at home. I can call them, we can discuss in their own home environment. I find that they appreciate, for sure, they like to see me for something they have to show me, but still they appreciate a lot telemedicine. And that's, I believe, most likely we could say it's a COVID-19 generation, if we want to say, because they learn, because it's now more than a year that we have been using telemedicine. At the beginning, it was very difficult, but now people, they say, yeah, it works. Like I told you today about the conferences. If it works to do Zoom conference, most likely after COVID-19, we'll continue doing Zoom conferences.
And did you see in your systematic review if there is any difference between the expectations or the satisfaction of caregivers and
It's too early. It's too early to answer because we are at the we are looking at the global. We don't have all details. It's we're expecting in 1 month we'll have the complete data analysis, because Marvel we're meeting next week. We'll look at what we have now. We'll do mapping. Most likely in a couple months we'll have final what we have. We'll answer that question at that time. But for now, what I showed the snapshot what we found.
There's a question in the chat from Pierre Pluy, if you want to give it a read, or I'll read it out loud.
Yeah, if you could read it, yeah.
Yeah, he says that he sees that one project included a review and a qualitative primary research study, but was called mixed methods research. Could it be simpler to call it qualitative research for two reasons? One, all research includes reviews, and also MMR includes qual and quant primary research usually.
Thank you, Dr. Priya. Thank you for your question. I know that you will ask that question. I know about that. The way why I present, because I'm trying to use the why I called it mixed. Maybe I'm wrong. Maybe you are my boss. I know, because I was trained by Dr. Pierre Priya when I came to the department. But I feel that my first study will help to conduct the second study. That's why I use it as a prerequisite for the second step. I know that some people, they use a mixed review like a prerequisite for their qualitative study, but I will update my questionnaire based on the results of what I find in the literature. That's why I still feel that it's a mixed method.
Yeah, but I don't know. Maybe I'm too old, and then the new generation and the new researchers will change things, which is fine. I think in my days, we mixed methods research was defined as the combination of qualitative and quantitative methods in primary research, in contrast to mixed methods review or mixed studies reviews, where you combine qualitative and quantitative methods in literature reviews. But when you do a review and the research, then it's qualitative or quantitative or mixed. So in your case, there is a review and the qualitative research, it's qualitative research, because the level of data was in the past, in the old days, again, the level of data, the way the meaning of the data, the status, the scientific status of the data is different. In review, you don't work with your own data. It's not, you have no control of the data. You really don't have access to the data. You don't have access to the participants. You don't know how it was done. And actually, usually the question of the other researchers is usually different from your question. So that makes the whole, it's another world. With different data, different participants, you have no control of different questions. And in some ways, you look at that from very far and make sense of that material for yourself. But it's not your material.
I see.
And that material was not collected to address your question. So that's why a review, whatever the review is, we all do a review when we do research. And so what counts as the primary research is the method used for the primary research. And then for sure, in literature review, if you combine different methods, then it's methods. Maybe things change. It's not the first time I see something like that. That's why I'm curious and ask the question.
Yeah, I know, because I looked through, I saw multiple research, research programs, because Dr. Vladimir wrote to me, you could use a research program using multiple methods. But for me, research program is something bigger. because still the first study were testing our hypothesis. But I also have the impression research program should be multiple projects together, and still it's still a small project. So I don't have that audacity saying that it's a research program. I still feel it's a study. But when I look through the through different mixed method studies that I found, very often they use the mixed method review as a first step, and then they are saying qualitative after. That's why I using that. But I agree with you, Dr. P. It's always we could just put it systematic review study 1, qualitative descriptive study 2. It's just terminology. Yeah. Thank you so much.
If you're not comfortable with the program idea, because I kind of agree, a program could simply be different research project, and one would be a systematic review. But there's also in grants, we also see a project includes phase 1 is a systematic review, and phase 2 is the data collection. So if you prefer to phrase it as all the same project, it's possible too with different kind of phases of your project.
Yeah. Mm-hmm. Thank you.
I have another question.
Yeah. Hi, Mira. How are you doing?
Great, thank you. Thank you for the great presentation. I had a question related to the attitudes of clinicians. So you looked into the attitudes of older adults towards use of technology and telemedicine. I was wondering if you looked into the attitudes of clinician, or if you had any experience in terms of, if there was any resistance in terms of using telemedicine or technology, or wasn't.
You're asking a very good question. That's another project that I'm looking at that with, because I'm working now with the student from the engineering department of McGill. We are trying to develop the project looking at the acceptance by the elderly patient using the applications to control certain health status. That's a different project. In this way, our focus was not on that, because we are trying to see the use of telemedicine during the pandemic. So it's not really our question for that project, but it's a very good question, especially when I look back and the results of the first study on the needs of the patients. What we found out, it's a problem with the education of the patient with the cognitive impairment. It's lacking, despite the fact that we have a lot of information that we provide. There is something that most likely we're not doing the way that they would like to have. It's an educational disease. That could be also a question, acceptance of technology, what their attitude toward the technology. Very good question.
Thank you.
This is a question kind of along the same lines, but not really about technology. But have you considered looking into the reasons why older persons might be hesitant to take some of these virtual methods? But is it based on like fear of COVID going in, or like the quality of care, of fear it's going to be worse quality of care versus better going in, or ease of not going in? Are you looking into those reasons why people might choose some of these methods rather than just if they are?
You're asking a very good question, and that's a question of our qualitative study, because we have a few questions about that. The idea, and you know what with the use of telemedicine, what we are facing now, we're facing now the risk to the continuity of care. It's one of the questions that was raised in a lot of publications, saying, because now patient, I have a back pain, I just click the button and I can speak to any doctor. I have a pain in my arm, I can click and I speak to any doctor available on the online platforms. And that's a risk to family medicine, because that breaks our continuity of care. So one of the questions that in our qualitative project, we're asking attitude to technology, and we ask also, would they prefer to follow by their family physicians, or they are open to be seen by any doctor who is available online? That's a question that we will ask them, because the family medicine, it's objective to provide continuity of care, and I believe that technology is one of the risk factors now for the continuity of care in primary care, because of the availability, because we have a lot of electronic platforms, dialogue we have, it started before, but we have others now that are available because our family doctors, they are busy. They are not always in front of the computer, but other platforms, they are always available. Just click the button and you can answer the question.
Thank you so much. I'll leave the floor open if anyone has some final questions. I know it was a smaller group today, so if anyone has any last minute thoughts, feel free to chime in. And then if not, we can wrap up soon.
I have one last question. I was a little bit surprised to hear that the old people found the technology fine. I guess they got used to it. I don't know if this is something you collected, whether they had family members or somebody else who helped them to set up the technology, because probably the issue wasn't using the technology, but to sort of set it up so that it works in the first place. Once somebody's set it up for you, you can probably feel fairly comfortable using it. But that initial setup, I think, I would have thought would be quite challenging for some of the old people. And I wonder if you got any feel for if somebody helped them with that.
Yeah, thank you for that question, Dr. Cocker. It's exactly the question that we found in all these studies. What we found, there is always somebody, who assists those patients in the literature. Even for the studies when they need to monitor the blood pressure, there is always somebody who would come earlier to establish that gadget, who will show how, and sometimes who will instruct which button to click when the phone call from the family doctor. That's why what we're trying to see, prior to COVID-19, yes, there is somebody, but what's about now? For our elderly patient, they are in isolation, they don't have anyone who could come to click the button. Even from CLC, we know about the nurses, they don't go to the elderly patient because they are scared to bring the infection inside. And the caregivers, they don't want anyone to come to them like an intruder. They consider CLC intruders. So in that case, that's why we're trying to see that something has changed because of COVID-19. They are more open, they are more skillful to use the technology. For the phone, it's not a problem unless there is a hearing impairment, but they prefer video consultation based on the literature review. So that's what we need to work on. If we see that the patients really COVID-19 patients, if they prefer video consultation, we need to work most likely with the development of some application that user friendly for elderly patients, that they don't need to click on multiple buttons to have a contact. Should be something simple, click here. That's all that they should have.
Yeah, that was my experience with people that, elderly friends or relatives. Just set it up so that I don't have to go into that program and do this and that. Just put it on the desktop, and I know that I click on that thing, and then it gets to me in one go.
Exactly what they need. A simple button, click here. That's all that they need.
Mind you, quite a lot of us would like that.
Yeah. But frankly saying, I would prefer also, I don't want to click multiple buttons to find something. Just want to click one button. That's all.
Okay, if there are no other questions, then I guess we'll wrap up here. Thank you so much, Dr. Khanassov, for your excellent presentation, and thank you so much, everyone, for attending. I hope you have a great rest of your day. Thank you, everyone. Just a reminder, next session is June 11th.
Thank you. Thank you. Bye-bye. Thanks. Bye-bye.